Okay, now we can actually get started. So salivary gland. Um, Types of glands are going to be the major and the minor, right? So the major are considered parotid, submandibular, and sublingual. And then the minor salivary glands, which are, as you know, pretty much all over the upper aerodigestive tract, the tongue, the palate, um, lips, buccal mucosa. And depending on the location and whether they are major or minor, the type of cell and the type of secretion that that cell produces is going to be different between serous and mucinous. And so what does that look like? So mucinous and serous. So one example of a essentially entirely serous gland is the parotid. And so that contains these very purple zymogen granules that are basically the pre-digestive enzymes for, salivary amylases, et cetera, right? So there are these very purple granules in the cell compared to the mucinous glands, which are more for lubrication of those mucosal membranes, right? So those are going to be essentially very pale, watery, whitish on H&E. There are some glands, including submandibular, that are mixed. So they have these serous kind of half moon shapes, and then the rest of the acinus is going to be mucinous. So, depending on where you are, you may be able to tell what gland you're in based on whether it's entirely serous, entirely mucinous, or kind of mixed. So just FYI for that purpose. You can see here that normal gland, right, is kind of an admixture of some fat, some glandular cells, and then these larger open spaces, which are the ducts. There's a couple ducts here and here and here. So one of the more common things that we see that's non-neoplastic in various, mostly minor salivary gland sites, generally in the lips due to biting, et cetera, are mucoceles. And so this is where you get these mucus extravasation processes and almost a pseudocystic reaction to the mucus extravasation. As I just said, mostly due to sort of lip biting or minor trauma. They can be clinically fluctuant with a waxing and waning course. And you can see here on the right that they are not lined by any epithelial or endothelial lining, but they're sort of lined by this fibrous wall with macrophages, specifically macrophages that have ingested the mucin, which we would refer to as mucophages. So here on the far right, the mucosa is up here, lining, and then giant pool of mucin. And so if this plunges sort of deeply into the floor of mouth or sublingual gland, it's a ranula. If it goes all the way through the muscle to involve the neck, through the mylohyoid, this would be a so-called plunging ranula. And as you may remember, this is derived from the appearance of the sort of gullet of a frog that has this sort of ball on its neck, frog being Latin rana, right? So hence that's where ranula comes from. I always like to know why we get the names that we get. That's a fun one. So sialolith, next kind of swelling that you may see in submandibular glands, right? Most commonly in the submandibular, but can be present in any duct. So this is kind of a mixture of various calcium phosphates that kind of organize around some kind of central nidus of bacteria, of mucus, of sloughed epithelial cells, right? And so they can be anywhere from very small in a minor duct to very large, right, in a major duct seen here on X-ray. Patients generally present with pain and swelling at mealtime, which makes sense, right, because they can't get the digestive enzymes out that they need to. On histology, if we ever see them, they look like these lamellated calcifications within the lumen of a duct. But, mostly we don't surgically resect these, as you know, but we do occasionally. Lithotripsy or massage, right, to get them out. You guys know better than I do what the treatments for these are, but on occasion, this is what we would see in a resected stone. So the next non-neoplastic thing that we do see biopsies for is Sjogren's syndrome. So what we're looking for is inflammation within the minor salivary gland of the lip, right? So easy site to access, rich in salivary tissue. What we want to look for is basically lymphocytes or lymphoplasmacytic inflammation. We grade this according to a focus score, where there's no infiltrate, slight infiltrate, moderate infiltrate, and then afocus. So afocus is at least 50 or more lymphocytes, well defined. And we score the most inflamed, essentially 10x objective field. And so anything with one or more foci is considered relatively predictive of Sjogren's syndrome. So that would be a grade 3 or a grade 4. Anything less than a focus is not really predictive. So in this case, we essentially see one small cluster of lymphocytes. And if you count them, 50 is not a lot, right? So each of these fields would represent a focus score of 1. Mostly these biopsies are done in patients in which the diagnosis of Sjogren is not, a slam dunk. And often the histologic features are also not a slam dunk. So, the most we generally see here is a focus score of 1, which, may or may not be clinically helpful, but at least we can provide some extra support in addition to the serologic studies and clinical clinical picture. One of the confounders in benign salivary is sialometaplasia, atrophy, sialidinitis. So, atrophy and inflammation can occur in various contexts, but in this institution, it's often secondary to chemoradiation to the head and neck for some other reason, for some other cancer. And so what we get here is essentially fatty replacement of the tissue. We get background fibrosis, we get lots of scattered inflammatory cells, but relative preservation of the ductal lobular architecture. So you can see here a nice central duct, right, with some lobules out at the periphery. And in general, the acini don't look as, I don't know how to say it, but juicy. I don't see as much serous zymogen granules. I don't see as much mucin. They kind of look small. The cells look small and shrunken. Often accompanying atrophy and fibrosis is sialometaplasia, which is essentially squamous metaplasia of salivary acini and ducts. And this also is generally in response to some kind of injurious stimulus, chemoradiation, ischemia. It can present in isolation as this ulcerated lesion on the palate. However, it is very often seen in small doses in as I said, in the context of chemoradiation of broader areas for other cancers. And so similar picture of preservation of the background ductal lobular architecture, but these acini and ducts become lined by epithelium that looks almost squamoid, kind of atypical with prominent nucleoli, but you may see retention of some of the mucocytes in the background. You may see this central kind of grungy debris. So this can be very, very challenging for some people, especially you may have seen frozens in which, the pathologist finds it hard to discriminate between cancer and squamous metaplasia. And this can be a very challenging feat, especially if you're not used to the kind of characteristic morphology. So just kind of a caveat with that. There are a couple of lesions that are kind of now becoming emerging possible neoplasms that we were not entirely sure previously if they were neoplastic or reactive. One of them is sclerosing polycystic adenosis, which is now potentially sclerosing polycystic adenoma, in light of the fact that it is potentially now thought to be neoplastic rather than reactive. Regardless, it's an indolent benign lesion, generally in the parotid of adult females. It kind of resembles almost like a fibrocystic breast disease where you have these multiple lobulated proliferations of ducts and glands and nests and myoepithelial cells, et cetera. Very heterogeneous in morphology, very, very rare. Actually, I don't think I've ever made the diagnosis of SPA, sclerosing polycystic adenosis or adenoma, but just one of the things to kind of be mindful of, it's benign. What we have found, though, is that the few cases that have been studied have shown mutations in PTEN that are recurring, and some additional PIK3 family mutations. So just interesting to keep your eye out for this in the future. Does anybody have any questions or comments on the non-neoplastic things before we move to the tumors?
Quick
Okay.
question. Can you say again what was difficult about sialadenitis? You said something about its presentation was hard. I just missed it. I can quite.
Yeah, sure. So more of sialometaplasia in the context of sialadenitis and atrophy. So sialometaplasia is when the acini and ducts of the salivary units transform to a squamous appearing epithelium. And it can look so atypical that it can be confused for squamous cell carcinoma, essentially.
Gotcha. Got it. Thank you.
No problem. Okay. All right. So tumors. So we know that benign tumors of salivary glands are much more common than malignant ones. Most commonly, we're dealing with the site being the parotid. Interestingly, the site with the highest rate of malignancies is sublingual. A little bit of sort of epidemiology and trivia there. Of all head and neck cancers, salivary carcinomas are pretty rare, only about 6%. The most common tumor period is pleomorphic adenoma. The second most common benign tumor is Warthin. The most common malignant tumor is mucoep, followed by adenoid cystic, followed by acinic. But we'll go through all of them. For a salivary mass, that is new, that is growing, that is not a stone, for example, right? FNA biopsy is going to be the preferred screening tool. And so just like we talked about last week with thyroid, there are discrete kind of diagnostic categories on salivary FNA that are sometimes used by cytopathologists to report the risk of malignancy. This is the quote unquote Milan system. You remember thyroid was the Bethesda system, sort of depending on where the people met to discuss the topic. But it ranges again anywhere from non-diagnostic to non-neoplastic to atypical to neoplastic to, suspicious for malignancy to malignant, right? So neoplastic can be either benign or malignant, but the bottom line is we don't know. Once you say something is malignant, that's usually something high grade because the cytology would be relatively aggressive for that. Many low grade neoplasms are very cytologically bland looking and can overlap with benign neoplasms, okay? And so that's why sometimes that can be hard to distinguish benign from low grade malignant. So some examples of what we might see in various Milan categories would be in the non-diagnostic. We might see just cyst contents that consist of macrophages. We might see normal salivary acini. So here's a nice sort of duct with a kind of this cluster of grapes, they say, surrounding its nuclei, very bland. This might be in something like sialadenosis, where you have swelling that might be mass-like, but not actually a tumor. Sometimes you can see swelling in chronic sialadenitis, and here you'd see, again, your normal grapes of acini, but in the background, these small naked nuclei of lymphocytes. In terms of neoplasms, there are some neoplasms that have an extremely characteristic appearance on FNA that we can determine definitively. One of those is adenoid cystic, and you may have heard the buzzword of sort of a gumball. So the stroma in adenoid cystic, as you'll see later on the histology, sometimes creates these sort of rounded nests, and it's the stromal fragments, which are these pink gumballs surrounded by neoplastic dark cells that are diagnostic of adenoid cystic. Pleomorphic adenoma would be the differential diagnosis here. The stroma in pleomorphic adenoma isn't quite as rounded and circular. It's more kind of wispy. Some people refer to it as troll hairs. I don't know who of you remember those troll dolls, right, from the 80s, but pleomorphic adenoma stroma can sometimes be called troll doll, but again, it has these bland, maybe not so dark, not so wrinkled nuclei in the background. Warthin tumor is very characterized by a combination of epithelial cells that have somewhat of an oncocytic appearance, as well as lymphocytes in the background. And then mucoepidermoid carcinoma here generally has these kind of monotonous intermediate looking cells punctuated by, you can see here, a very nice vacuolated cell that has intracytoplasmic mucin, right? So this is mucin, nicely characteristic of mucoep. So sometimes we can make this diagnosis, sometimes we cannot. And sometimes we just say something like low-grade salivary neoplasm, high-grade salivary neoplasm, something like that. Because, when you're dealing with a primary parotid lesion, generally the treatment for benign and low-grade carcinoma is essentially the same, meaning surgical resection with negative margins and observation. So if you see us hedging on FNA or on core biopsy, which is less common, that's because we understand that generally the patients are going to get the same treatment. They're not going to get a neck dissection at the time of surgery. They are, going to get, hopefully a margin clearing surgical resection for whatever it is, and pause there and wait for the final, So in most cases, that will be enough, right? In most cases of a low-grade salivary neoplasm, whether it be an adenoma or a low-grade carcinoma, that is enough. However, we really try to state if something is high grade, or for that matter, if something could potentially be adenoid cystic, because whether it's high grade, any subtype, or adenoid cystic, these have higher risk of metastasis to local regional nodes. So these patients are more likely to undergo neck dissection at the time of initial surgery, and then potentially chemoradiation following surgery, depending on the remainder of the clinical pathologic parameters. One thing I do want you to keep in mind is that because we are in a highly lymphatic draining region, right, whether it be the parotid, the submandibular, the upper neck area, right, this is highly possible that we may have metastases to these regions in the areas of the glandular tissue, right? So you have intra and periglandular lymph nodes, to which mostly cutaneous carcinomas can metastasize, because that is their patholymphatic drainage. So cutaneous squames, cutaneous melanomas, cutaneous Merkel cell carcinomas have all been seen to metastasize to the parotid region or periparotid region. So that's one final thought to kind of always keep in the back of your mind. Sometimes the patients have occult primaries. They have no known skin cancer, but there are various ways in which we can sort of prove that these are skin cancers in the end. And we'll talk about that a bit later. Certainly treatment for these depends on the overall remainder of the disease status for that patient. So once, we have a biopsy and the decision is made to operate, the role of the surgical pathologist then is to confirm whether this is a salivary primary versus a metastasis, confirm again that grade, low versus high. In many cases, grade is more important than the actual histologic subtype of salivary cancer. We'll talk about all the various subtypes of cancers and some of the common morphologic features between, low grade and high grade. But now we have a lot of genetic backup for our histologic subtyping of salivary cancers. We used to be kind of in the dark with it's pleomorphic adenoma or not for the benign tumors. But now we have a lot more information based on morphology, immunostaining, and genetics, and we can really fine tune our diagnoses. We, of course, comment on the margin status, and then if it's a cancer, the TNM stage. So I wanted to give you kind of an overview of salivary types of neoplasms in terms of, how I like to think of them. So I like to think of them in terms of, are they benign or malignant, or do they have both benign and malignant counterparts? For example, pleomorphic adenoma can transform, right, to carcinoma X pleomorphic adenoma. Basal cell adenoma is morphologically similar to its invasive counterpart, basal cell adenocarcinoma. For example, adenoid cystic just is, right? It doesn't have a benign counterpart. And then how many cell types there are? Is it monotypic, meaning there's one cell type, or is it biphasic? Are there two cell types? Or very rarely are there three cell types that would be seen in essentially only mucoep? So depending on the breakdown, how many cell types, and potentially what are the gene rearrangements, we can get a really good handle on what type of lesion we're dealing with. Before I get into the nitty-gritty about the individual subtypes, do you guys have comments or questions so far?
How commonly are you testing for all these genetic mutations and diagnoses that are otherwise straightforward?
Not very. So when the diagnosis is straightforward, there's really no need to test for it because many of these are low grade and wouldn't need any clinically actionable sort of molecular testing. The times we do molecular testing is one, if something is high grade and we're just probing for any actionable mutation, right, that might have some chemotherapeutic agent or prognostic value. Two, anytime that the diagnosis is uncertain, meaning we can't make a distinction between is this a benign cystic lesion or a cystic low-grade mucoep, then we might probe for the, the mammal, gene rearrangement to make a definitive diagnosis of a malignancy. Also, if there's always newly described entities that are kind of being pulled out. So one of those, as we'll see later, for example, is like secretory carcinoma. So secretory carcinoma used to be thought of as a variant of acidic, but now we know that there are genetic differences. And so to kind of give ourselves a little holding hand as a pathologist, if I see something that looks like secretory, I might do the genetics just for my own diagnostic confirmation for the first few cases. Once I get a hang of it, I'll stop doing the genetics because it's a waste of money and just make the diagnosis based on morphology and immunostains once I achieve a level of comfort. So those are the various reasons in which we do molecular testing, but more often than not, these are histologic diagnoses that we don't pursue molecular because it's not going to really add much information beyond that.
Thank you.
Mm-hmm. As we go through each of the individual tumors, we'll talk about what molecular mutations may be important and may be actionable within each tumor kind of group. Okay, so when we have the neoplasm on our desk, what do we do as pathologists? So one of the most important things is the edge of the tumor. So circumscription is a pretty good indicator of a benign tumor. Occasional malignancies can be circumscribed, but infiltration in salivary gland, infiltration into the adjacent parenchyma or adjacent organs is the best indicator of malignancy. So that's thing one, so low power. Thing two is we look at the number of cell types, 1 or 2, or as I said earlier, occasionally 3. So, right, is it monomorphic? Is it monomorphic epithelial or monomorphic myoepithelial? Is it biphasic, meaning epithelial plus myoepithelial? And then we look at the morphologic pattern. Basaloid, cribiform, tubular, cystic, secretory, solid, nested. So we use all of these features with selected use of immunohistochemistry and occasionally genetics to make a diagnosis. So I'm going to start with the benign tumors that also have malignant counterparts, and you can see here. What used to be called in the literature monomorphic adenomas, in the 70s and 80s, we now can really sort out into these various discrete histologic types. So pleomorphic adenoma we'll start with and spend a bit of time on because you'll see this most frequently. Grossly, the edge is well defined. It often has this white, tan, glistening cut surface that often resembles cartilage because, as you'll see, this often has a chondroid stroma. It's called pleomorphic adenoma, not because when we talked about pleomorphism in terms of nuclei, pleomorphic nuclei usually mean wildly atypical, large, small, dark, light, prominent nucleoli, mitoses. Unfortunately, in pleomorphic adenoma, it's a little bit of a misnomer because these are not pleomorphic cytologically. They are polymorphous or heterogeneous in terms of their architecture, as you will see. So it's a little bit of a misnomer, but I'll show you that in a second. PA is defined by biphasic nature, being epithelial and myoepithelial cells forming these bilayered ducts. So you can see here an inner luminal layer and an outer myoepithelial layer. And then in the background, this myxoid stroma. Occasionally, you have these very small individual myoepithelial cells that kind of percolate through the myxoid stroma. The myoepithelial cell component can be quite variable morphologically and variable cellular. cellularly. So they can be very paucicellular and kind of inconspicuous and flat. They can be plasmacytoid or plump, resembling plasma cells here in the middle. They can even be highly spindled and resemble a mesenchymal neoplasm. But as long as you see some evidence of a conventional pleomorphic adenoma with chondromyxoid stroma and biphasic ducts somewhere, you can make a diagnosis of a pleomorphic adenoma. So you can see here on the left cartilage, you can see here in the middle chondroid stroma of a pleomorphic adenoma, and then that low power appearance on the right, some of these pale chondroid islands and some of these very dark cellular islands, and then non-neoplastic salivary tissue on the left. We occasionally see tyrosine crystals in the stroma that is essentially unique to PA. It's meaningless otherwise, then it's kind of pretty, but I'll mention it because we sometimes see it. So what can PA do that is unsavory, right? So pleomorphic adenoma can most prominently recur, right? Especially after incomplete excision, and it can recur in terms of multiple small nodules in the region. It can sometimes metastasize and maybe inappropriately be called benign metastasizing PA. Benign because it looks cytologically very bland, but some patients with quote unquote benign metastasizing PAs have experienced mortality due to metastasis. This is a little bit of a controversial subject, so maybe we'll pause on that for now. But what it can do, and we do know, is transform to a high-grade invasive carcinoma, which we refer to as carcinoma X pleomorphic adenoma. It can resemble any type of salivary carcinoma. It's often just nondescript or salivary duct or myoepithelial or epithelial myoepithelial. But as long as you can find a residual pleomorphic adenoma in the background, it would be, you know, whatever type of carcinoma XPA. These generally are always quite aggressive. There is a form of in situ carcinoma that we think is a precursor to the invasive carcinoma X, that is nuclear atypia and mitotic activity confined within the pre-existing PA. And as long as those are resected without invasion, those generally are indolent behavior. So this is what recurrence looks like. These multiple very small lobules within the fat, within the muscle, within the rest of the glandular tissue. I kind of like to say almost kind of buckshot. This is diagnostic of recurrence. Carcinoma X, which is increasing with every recurrence that a patient, you know, has, is thought to be about 12% of all salivary malignancies, and happen in about 6% of all PAs. By definition, is a malignancy with the evidence of adjacent pre-existing PA or malignancy in the same spot as a prior resected benign PA. Invasion versus non-invasion, as I said earlier, is really definitional of prognosis in these patients. So the in situ variant looks like it has cellular atypia with nucleoli and mitoses. The invasive variant has, you know, these tongues of tumor that percolate into the background stroma. And here's the pre-existing, often burnt out or hyalinized pleomorphic adenoma in the background. Here's another example of the hyalinized burnt out component on the right, the invasive component on the left. And it's thought that the precursor lesion arises within the ducts of the PA, as you can see here, and then invades outward. The genetics of pleomorphic adenoma are generally PLAG1 gene rearrangements or HMGA2 gene rearrangements, seen here. There are some tumors that are composed entirely of myoepithelial cells, but those are quite rare. One might perceive that they are myoepithelial rich pleomorphic adenomas. That's my opinion, but there are some people that report pure myoepitheliomas of salivary gland. There are myoepithelial carcinomas, which are distinguished, of course, by their infiltrative growth. They can transform from pleomorphic adenoma or arise de novo, and they often look as follows, with large nests with central necrosis, with these cords of myoepithelial cells that are quite plump within this mucinous stroma. So that's myoepithelial carcinoma. Wharton tumor is our second most common benign. It is often quite cystic and has this kind of grungy fluid in it, often in smokers, often bilateral, often PET avid. This is one thing I do want to mention. People nowadays are getting PET scans for everything, right? And so often they're smokers, they have lung cancer, they have colon cancer, they get a PET scan. Oops, something pops up in their parotid. It is quite often a Warthin tumor. And we can easily diagnose these commonly on FNA. And sometimes they would undergo subsequent resection, sometimes just clinical observation. But they are these cysts lined by oncocytic epithelial cells with background lymphoid stroma that, occasionally are thought to potentially transform, but really, 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 really rarely. We remember talking about oncocytes with thyroid, but just as a reminder, right, these are mitochondria-rich, very pink cells. Perhaps the mitochondria richness may account for the PET avidity because they're uptaking all this glucose to, for metabolic energy, et cetera, et cetera. This is in contrast to oncocytoma, which is purely oncocytes and does not have the background lymphoid stroma. So you can see here purely sheets of oncocytes without lymphoid stroma. Sometimes it has clear cell change. And sometimes you can see multiple foci of oncocytic nests within the parotid parenchyma. Here's one, here's one, here's one, here's one. Here's clear cell oncocytic nest. Oncocytosis or oncocytic hyperplasia is really common, especially in elderly patients. And so sometimes you can get one of these foci of oncocytosis that kind of blows up and then becomes essentially an oncocytoma in the background of oncocytic hyperplasia. We just had a case not too long ago of this. I don't know if any of you were on that surgery, but kind of interesting, essentially benign process. However, there are oncocytic carcinomas that are defined by mostly high-grade cytology and infiltrative growth. You can see here that one end of the tumor is kind of circumscribed and the other has these tongues projecting into the background. But the cells themselves are oncocytic. Once it becomes necrotic, mitotically active, then you start getting high-grade. And these are some of the features we look for in general in high-grade carcinomas. Is there increased necrosis? Is there increased mitosis? Is there necrosis? Are there things like perineural invasion, lymphovascular invasion, et cetera? These are features that are common amongst high-grade cancers. Basal cell adenoma is another benign that is defined by its kind of blue or basaloid appearance with peripheral cellular palisading and then these pink hyalinized stroma in the background, which I'll show you. They're defined by mutations of beta-catenin, CTNNB1, and occasionally mutations in the CYLD1 gene. So if you remember, what is CYLD1? It's the gene that causes these syndromic, like dermal cylindromas, the turban tumors in the heads of people. So that's the same gene that you can occasionally see mutated in BCAs. Here's a low power of a BCA, very, very blue. Higher power, you can see this peripheral palisading at the edge. You can see these pink eosinophilic stromal globules. That's probably basement membrane type of material that's secreted by the tumor cells. You can find beta-catenin nuclear expression in these tumors, which is a surrogate marker for beta-catenin mutation. All right, so that can be helpful diagnostically. Here's the turban tumor, right? Here's the basal cell adenocarcinomas. That CYLD gene loss can be seen in the dermal cylindromas and in basal cell adenomas and basal cell adenocarcinomas. But like most salivary tumors, right, basal cell adenocarcinoma is defined by its infiltrative growth pattern, right? So the tumor nests inside might look the same, but it's the periphery, it's the edge that defines infiltration and that defines malignancy. But otherwise, you can see here that it may appear quite similar in the internal structure of the tumor with the basement membrane material, et cetera, especially if it's a low-grade malignancy. High-grade malignancy, again, you'd start to get necrosis, mitosis, et cetera. Canalicular adenoma is a rare one that we see, but is very clinically kind of selected to mostly the upper lip, mostly of older kind of females. This is considered a monotypic tumor with these very thin cords of cells and this background myxoid material. No known genetics in these, but very, very characteristic clinical pathologic correlation here. All right, now, before we move on to the purely malignant tumors, do you guys have any questions on the benign or the benign with malignant counterparts? Okay, cool. We have about 15 or so minutes left. So these are the tumors that really are only malignant. So if you see them, you're dealing with a malignancy, then you have to determine, are they low grade or high grade? So we'll start with the most common being mucoep. So epidemiologically, we know that mucoep can present in both adults as well as children, right? So this is one of the rare carcinomas that we do see in kids, both major and minor salivary glands. 3 cell types, as you'll see, genetics being specifically CRTC mammal 2 or CRTC 1 or 3. So it can present histologically as either solid or cystic or some combination of the above. But definitionally, we must see these cell types. The cell types being mucinous, these cells with pale intracytoplasmic mucin, intermediate, which are these kind of nondescript bland cells with small nuclei, and then on the right, squamoid, very much resembling squamous epithelium with intercellular bridges, prominent cell borders, a little bit more prominent nucleoli. All right, so this is the micro appearance of mucoep. We can confirm the presence of mucin by PAS immunostain. So PAS stands for periodic acid shift. Don't worry about it. But if you see PAS, that's often what we're doing. So PAS itself can stain things like glycogen, which we see in squamous cell carcinomas, for example. But PAS, you can stain with PAS and then apply a second treatment called a diastase or an amylase. And the diastase will actually digest out the glycogen, but it will not digest out the mucin. So the mucin is diastase resistant. So if you do a PAS and a PAS diastase and it is preserved, then you know that what is the material in these cells is most likely mucin rather than glycogen, which can help support your diagnosis of true mucin in mucoep, if that makes sense. So if you see these stains in our reports, that's why we're doing them, to differentiate that clear material in the cells. The grading of mucoepidermoid carcinoma has been fraught with problems. There are currently 4 grading systems out there in the literature, 2 that are qualitative, the Healy on the left and the Katabi from Memorial on the right. The 2 in the center, the AFIP system and the Brandwein system are quantitative, where you actually add up the numbers and come up with a low, intermediate, or high. Interestingly, if you apply these 4 grading systems to the same tumor, you could get anywhere from a low to an intermediate to a high grade, depending on what system you use. So it's like absolutely terrible. The AFIP tends to grade tumors lower. The Brandwein tends to grade tumors higher. And the Katabi and the Healy kind of are in the middle, based on studies that we've done here at this institution. And so what we've found is that if you use the Brandwein system, anything that is low or intermediate grade is generally clinically biologically indolent. Anything that is Brandwein high grade should be generally regarded as a possibly biologically high grade. So, we try to avoid intermediate when possible because it's uncertain what the treatment for this should be. But I would argue if you're using the Brandwein system and it's intermediate, this is probably a biologically indolent tumor. And so that's the approach that we've taken here, because the low and the intermediate grade, as you can see, seem to cluster closer in terms of recurrence and survival, et cetera. So that's how we have taken the approach for our practice. So if you're out in the world, always ask your pathologist, like, what system are you using? Because that may change how you tackle these low, intermediate, or high grade tumors. Okay, questions? All right. Second most common malignancy, adenoid cystic. This is the one, as you know, that very frequently has perineural invasion, and so these patients can have experienced significant nerve pain. These patients have aggressive courses with local recurrence, with metastasis to lymph nodes, to lung, et cetera. They are defined by 2 cell types, which you'll see in a minute, and the genetics, which are MIB NFIB gene rearrangement. Some of them have notch mutations. It's thought that the notch mutation may portend more aggressive behavior, I think there's now some clinical trials for Notch inhibitors. So this is one area where molecular testing may be useful, not only diagnostically for adenoid cystic with the MIB, but also prognostically and therapeutically for the Notch1 mutations. So here's what it looks like a Swiss cheese or cribiform or sieve-like growth. This is the most common pattern that you're probably going to see on your exams. And if you remember the gumballs I was talking about on the cytology, well, the gumballs are basically these blue basement membrane material that are pulled out as these balls, right, surrounded by these wrinkly tumor cells, right? So that's the correlate there. They can be tubules as seen in the middle, and they can be these cribiform or sieve-like structures. Here's an example of what perineural invasion looks like on the left, where it's sort of hugging or wrapping around the nerve. Examples of the morphology, on the left being more tubular, on the right being more solid, and then in the middle being cribiform. And it's thought that the more tubular, potentially the more low grade, the more solid, the potentially you're creeping towards a more biologically high grade. So that's how we tend to grade it, or at least we tend to report what the predominant morphologic subtype is. We can confirm the two cell types by immunohistochemistry. Epithelial cells stain for c-KIT in the cytoplasm, myoepithelial cells stain for P63 in the nucleus, and you can sort of see this epithelial myoepithelial kind of sandwich packing structure. I have already mentioned tubular cribiform solid may portend some growth prognostic differences. However, the worst thing that adenoid cystic can do is sort of de-differentiate or transform to a very high-grade tumor with increased metastasis and decreased survival. So on the left is your high-grade, is your solid regular variant adenoid cystic, in which the nuclei are still bland and small and not very mitotically active. On the right is your high-grade transformed adenoid cystic, in which the nuclei are bigger with bigger nucleoli, more mitoses. So this is so-called high-grade transformation or de-differentiation. And high-grade transformation can occur in pretty much essentially any salivary gland carcinoma. And you may not be able to tell what the underlying low-grade component was unless you have a morphologic evidence of it, or you do genetics to figure out what the soul of it is, right? So this, once it's a high-grade carcinoma, it can sometimes be really hard to tell what the morphologic subtype is, if that makes sense. Polymorphous I put next because it can be a histologic mimic of adenoid cystic because the morphologic patterns overlap. The most common location for polymorphous is the palate. It is cytologically uniform. It only has a single cell type, as you'll see in a minute, unlike the two cell types of adenoid cystic, but it does have perineural invasion. It can have morphologic overlap. It has often mutations in the PRKD1 gene, so this can be helpful diagnostically. You can see here these various growth patterns from tubulocystic to kind of almost whirling to solid. The nuclei tend to have more open vesicular chromatin compared to adenoid cystic, which tends to be dark and wrinkled. And the interesting thing to discriminate polymorphous from both of other biphasic neoplasms. So remember, pleomorphic adenoma was biphasic, right? Epithelial and myoepithelial. Adenoid cystic is biphasic, epithelial and myoepithelial. Polymorphous is not, it is monophasic. So it would be negative for one of the myoepithelial markers, specifically negative for P40. So that's helpful in distinguishing in this morphologic differential diagnostic grouping. There is a variant of polymorphous that is now recognized, so-called cribiform. This tends to be more in the non-palatal minor salivary glands like tongue, buccal mucosa, etc. It is morphologically, immunohistochemically, essentially identical, except for two things. One, it has more frequent incidence of lymph node metastasis than polymorphous arising on the palate, and it has PRKD gene rearrangements instead of PRKD gene mutations. So kind of an interesting morphologic kind of dichotomy here between polymorphous and cribiform. All right, moving on to acinic. This is essentially sheets of serous acinar cells. we now know molecularly are both NR4A3 and this MSANT-D3 gene rearrangements, kind of recent here, but the morphology of a cynic is usually so clear that we don't do the genetics. It's just sheets of these serous acinar cells. You can prove that they're acinar with, again, with PAS diastase. So the other cell component that is resistant to digestion by diastase are these zymogen granules. So again, you can make out these really dot-like purple granules that do not get digested out. That can be confirmation of a cynic if need be. However, as I mentioned before, high-grade transformation is also possible in terms of this high-grade mitotically active, et cetera, neoplasm, in which now your behavior is worse, right? So these are the patients that are going to undergo neck dissection, chemoradiation, et cetera. These low-grade, just clinical surgery and observation. All right, secretory carcinoma is the next one that was described, what are we now, 13-ish years ago, due to its resemblance to the similar carcinoma in the breast and its identical gene fusion, which is ETV6 and TRAC3. These are generally considered low-grade, but can also undergo high-grade transformation. They tend to have very heterogeneous architecture, cystic, microcystic, papillary, but the common thing is they all produce some kind of secretory material. So it's usually pale and watery and present within the lumen of these microcysts. It can even be vacuoles located within the cytoplasm of the cells. It has a characteristic staining pattern, which is S100 as well as mammoglobin. Mammoglobin is generally a breast marker, but it stains this tumor that resembles the breast cancer. It can have high-grade transformation, as I said, and that's all about secretory. The other tumor that resembles breast cancer is salivary duct. Salivary duct is essentially uniformly a high-grade cancer. It is important to recognize for the likelihood of its expressing androgen receptor as well as amplification of HER2. So why is this important? Because these patients can be treated with androgen antagonists, right? Or Herceptin. So we often probe our high-grade salivary cancers, specifically salivary duct, for AR and HER2 because of the treatment implications. These salivary cancers are essentially uniformly ERPR negative. If a salivary cancer is ERPR positive, it's probably a metastasis from the breast. This can happen. So just be mindful of that. So here's what salivary duct looks like, kind of these large nests. You can see cribiform spaces like in adenoid cystic, but the difference is in the cells. So in adenoid cystic, the cells are really dark and shrunken and blue. In salivary duct, they're really big and pink and kind of apocrine-like, if that makes sense. But these are highly infiltrative, highly aggressive, perineural invasion, vascular invasion, et cetera. This is one of the more common carcinomas I mentioned earlier that we see also transforming out of pleomorphic adenoma, but it can occur de novo or it can occur transformed. There are these also low-grade intraductal carcinomas that some have previously considered a variant of salivary duct. Whether that's true or not, I don't know, but I will just mention them because if these carcinomas are completely confined within a ductal system, meaning bounded by an outer myoepithelial cell layer, and the proliferation is completely within the lumen, these are low-grade, essentially in situ types of carcinomas. These are pretty rare, but if you ever see intraductal, that's what that means. Epimyoep is a rare variant that is defined by these bilayered ductal structures that tend to have very prominent, clear myoepithelial cells at the periphery, unlike the other tumors we've seen, and HRAS gene mutations in many of them. So on low power, they kind of look like the myoepithelial carcinoma we saw earlier, but if you look carefully, you'll see these little tiny ducts that punctuate in the background of these cytoplasmically clear myoeps in the background. All right, so that's epimyoep. These are also generally high grade on balance. Lastly, what other clear cell tumors can we see? We can see hyalinizing clear cell carcinoma. This tends to be mostly in minor rather than major salivary glands. Interestingly, these stain exactly like a squamous cell carcinoma with high molecular weight keratins and P63, P40. They are negative for other myoepithelial cell markers, like any of the contractile ones, like SMA, smooth muscle actin, or calponin, et cetera. I know we didn't talk specifically about those earlier, but just kind of to mention briefly right here. But they are defined by the EWSR1 ATF1 gene rearrangement, which is identical to the clear cell odontogenic carcinoma that you see in the jaws, in the mandible or the maxilla. So this is kind of an extraosseous versus an intraosseous clear cell carcinoma with identical gene rearrangements. And so we have used genetics in this case to help make this diagnosis in equivocal cases. Hyalinizing because it has these very pink stromal hyalinized bands in the background. There is this rare lymphoepithelial-like or nasopharyngeal-like carcinoma that can occur in the parotid that is sometimes associated with EBV. You can see here this very syncytial growth pattern, immunohistochemical markers for squamous differentiation. Whenever we see something with a virus out about in the world, whether it be in the parotid, the neck lymph nodes, whatever, whether it be EBV, whether it be HPV, we always want to kind of exclude a metastasis, right, from EBV, nasopharyngeal carcinoma, or HPV, oropharyngeal carcinoma, right? So presence of virus out in the neck or the glands is highly suggestive of a potential metastasis from those sites. It's 9 o'clock, I'm almost done. The other place in which we want to exclude a metastasis is true keratinizing squamous cell carcinomas of the parotid gland, which essentially are, we think, rare to non-existent as salivary primaries. They are mostly metastases from cutaneous primaries. And the way we prove that is by doing genetics for ultraviolet signature mutations, which has these characteristic C to T or CC to TT, base pair changes due to DNA cross-linking, right? And so if you see extensive changes as this on next-gen sequencing, you may be able to say, oh, this looks like an ultraviolet signature. What's an ultraviolet signature doing deep in the parotid? It's not, it's a metastasis from something that originated in the skin, okay? And that's how we can prove these are cutaneous mets. I already talked about the EBV and the HPV, so I won't recapitulate that, but just kind of an interesting way that genetics has helped us in the past. It's thought that the metastases from the skin, patients tend to do better than other primary high-grade salivary carcinomas, interestingly. So just something to keep in mind. So a skin met may actually portend a better behavior than a primary high-grade salivary cancer. Cool, so that's it for salivary. Do you guys have other questions? Okay. You're welcome. I will send out, I'll probably send out a link to my YouTube channel with the recordings. Do you guys want copies of the PowerPoints as like PDFs as well? Or is the recording enough?
I think both would be great if you can put that together.
Yep, that's not a problem.
Awesome. Thank you so much.
You're welcome. Come visit us anytime.